sometimes you see, but you don't see the brain. Okay? So, there's something called physiofeature. Okay? Because there's biofeature, such as weight, height, blood pressure. There is also physiofeature. What's physiofeature? Is the function. So Mustafa gets sick. When he goes to a doctor, examine him, he find nothing. But Mustafa feels he's not okay. Because Mustafa is talking about the function, about the physiofeature, and the doctor is checking the biofeature. Not yet. The function is there, but there is no structural changes yet. So that's the idea, what we call it, physiofeature. Is the changes that normally happen in our body. What's the changes? So let's take heart rate. Okay? Now the heart rate, there is number of heart rate per minute, and per hour, and per day. There is range. Okay? That's normal, that's a biofeature. But there is changes beyond that. We don't see it. The first change that happened is event to event variability. Your heart rate never fixed. We say the heart rate is 110, but it's actually changed every second. 119, 121, 110, it goes up and down. So event to event variability is a sign of life. It's a physiological sign. So if we can find it, we can see something in the heart rate, usually we don't see. So that's the first thing in the heart rate. B, there is sleep, wakefulness cycle. There is changes in the heart rate during your sleep and your wakefulness, during your melatonin and during your serotonin. These changes normally happen. Okay? See, there is changes with pleasant and noxious stimuli. Your heart rate will change when you're drinking coffee because it's enjoyable. Your mother is there. You're hugging your daughter.
Emotional.
Any pleasant stimuli, quietness, taking paracetamol, all are pleasant. Having milk, eating, driving, whatever pleasant. Your heart rate changes regarding the event to event will change, depend on the person. Or in pain, or noise, or somebody's upsetting you, or somebody's doing procedure. Your response to pleasant and noxious stimuli, we can read it. So you see, the first was what? Heart rate. We didn't see that event to event variability. We didn't see sleep wakefulness cycle. We didn't see changes with pleasant and noxious stimuli. D, rhythm change. There's always we have a rhythm based on the working hours, resting hours, eating hours, enjoyment hours, sleeping hours. You will have rhythm. Everybody of us will have rhythm. So if I take the heart rate of Asif over 1 week, then I compress it. And then I take picture. Then I take the heart rate of million people and compress it over a week. The computer will recognize Asif of all of that by its picture, because he has his rhythm on. Is always different from everybody else. Unique. It's unique for him. Okay? So rhythm changes. Event to event variability, sleep wakefulness cycle, affect your heart rate. Okay? So physio feature. Now this is one. Second is your physio ID. Each output of our body, or what we call the vital sign, it's an output based on event-to-event variability, based on sleep-wakefulness cycle, based on changes with pleasant and noxious stimuli, based on real rhythm. And rhythm can be daily, seasonal, annual. Okay? These changes is particular for everybody. So if we take the heart rate, if we take the temperature, if we take the blood pressure, I can identify each and every one of them. So if you go to the system, okay? You get physio ID. All this is particular to you. It's called physio ID. Okay? The third one is your patho feature.
Changes.
These things are changeable or fixed for one person in particular?
These are all fixed for everyone. But there is common in each. So let's say we take the picture of Asif, of physio feature and his physio ID.
It will be different.
And then we take 10 people like him. There will be common. This depends on gender, age, ethnicity, environment. So if we take 10 from Tabuk and we take the physio ID, it will be different from 10 people, same character, in a different city. So there is common, but there is specification. There is peculiars for each one. Okay? Now, these will change, the batho features will change, or the vital signs, or the output will change based on the disease. So if you're sick, if you have UTI, so I was working on diagnosis of E. coli UTI by your heart rate. What are the changes in your heart rate if you get E. coli UTI from the changes? Okay? So this is called patho feature. Now we go to something called presentation. How we present how we present these, how we see it. Okay? So the presentation. Now we talked about event-to-event variability. We talked about rhythm. We talked about cycles. We talked about response to pleasant and noxious stimuli. But how we see it? We have to present it. So we have to take the data and then present it in a meaning way. The first presentation is table. So you have number and you have the data. So let's say 120 heart rate, 130, 119, 116, 100, and then how many times, how many numbers in 24 hours. So stable. The second presentation is, oh, I always forget that I can do everything together. The second presentation, so table, the second is linogram. So instead of listing it, I will go like this. This is real-time linogram. But what I can do is I can compress it. Instead of seeing it every second, I will compress it all, and I will see it over 24 hours. So I will get something called tachogram. And I will tell you each one what you will do with it. Compression, you will get tachogram. And then we have something called Poincare. I will show you each one. And we have to go to Google, right? Here? Or no?
Yes, we can. Google, yes.
How we can go to Google?
We have to من هنا لا we have to skip this page يعني. مفيش؟ لا خلاص يا دكتور. انترنت معلش.
ما في انترنت؟
No.
ما في. Okay. So we can say Poincare. Poincare will give you your physio ID because المعالج الفرنسي اكتشفها. It will be like this. So you have the event to event with next event to event. And then you get shape. And in that shape you have length, you have width, you have the distance, the hysteresis, you have the distance from here, it's all standard deviation, and you have the direction. And I have very good, nice study, I did it. I start to identify gestation by their heart rate. So once I see the shape, I'll tell you this is 24 week. Okay? And even we start to know what's the age of the baby from the shape, from the Poincare. So Poincare is very good physiology. So we can identify people from their, their pattern, their event to event. Okay? So we have tachogram, we have Poincare, and we have histogram. Okay? The histogram, so tachogram will show you the rhythm, wakefulness, sleep wakefulness cycle. Poincare will show you the physio ID. Linogram will show you the event to event variability. And histogram will show you a period, will show you centralized and lateralized pictures. Okay? That is what we call it smart monitoring. Looking at the signs beyond the visible. And now I will show you real life scenarios. Based on?
I don't understand the difference between histogram and tachogram.
Histogram show you the period. Where you were, what is the most common period? Where you were happy all the day, where you were sad all the day, you show you your period. Because remember, you have response to noxious stimuli, you have response to pleasant stimuli. Histogram will show you where you were in that day. Where you were in happy, You were sad or you were everywhere? We show you. The tachygram will show you the rhythm, your rhythm, how you behaved in us. We should not show you, we don't know where are you, but we show you rhythm. A linogram and table will show you the event-to-event variability. I will give you an example and you will understand. Okay? So I will give you, do you guys have here NIRS or no?
Yes,
Near.
no.
No, you don't have NIRS. Okay, no. So you know what is NIRS, right?
Yes. No.
It is a tissue oxygenation. It's a venously weighted assessment, while the pulse oximetry is an arterially weighted. So pulse oximetry measures the saturation of the hemoglobin out of 100 in the artery, while the NIRS measure in the vein. So the difference is oxygen consumption. Okay? So I will use this example because it has many benefits.
But you use NIRS mainly for the brain perfusion and
I
so
will tell you. I will show you.
Okay.
Now I will give you an example.
Okay.
Which one is the most important organ in the body?
No. Brain and heart.
Brain.
Yeah.
Okay, and believe it or not, during resuscitation, we measure everything but the brain.
Mm.
Okay? So let's say we are doing NIRS.
Non-infrared spectrograph.
Near infrared spectroscopy.
Oh, yes.
So we have visible light, which is 0.2 to 0.6 microgram wavelength that we see. And then we have thermal light, which is 800 to about 1400 micrometer. And in between, there is an area between the visible light and thermal light. Okay? Which is the infrared. It's called near infrared. And it's usually from 600 to 800. Okay? Now the wavelength of saturated hemoglobin is 620. Okay? And that's the same as the red light. And it can be measured by NIRS. Okay? So we have pulse oximetry, give you the saturation in the artery. And you have NIRS, give you regional oxygenation in the vein. The difference, this minus this, give you oxygen consumption. Okay, now let's put the NIRS on the kidney and let's put it in the brain. And we start reading. Okay, which one? Now remember the regional oxygen measured in the vein. And here is the brain. Which one will be higher? This one or this one? And why?
Brain.
Brain will be higher.
Consumption of oxygen.
Okay, so because remember this is vein.
Yeah.
So which one is consuming more?
Brain.
So which one will be low? Brain.
Yes.
So the amount of oxygen in the vein will be less. The vein coming from the brain. Correct?
Yes.
Because kidney consume less. So that's one. This will be lower. This will be higher. Second, which one should be more stable consumption?
More
Which one consume oxygen should be stable, never change?
brain.
Brain. Kidney has to change. Why? Because that's autoregulation. When the brain suffers, who will be deprived? The kidney, the heart, the bowel. So which one is more variable?
Kidney.
And which one is stable? So if you stop variability here, what does that mean? Give up.
Yes.
Autoregulation is not working anymore. Okay? Because all the organs are in the service of the master, brain. Brain always. Sugar should be stable, fluid should be stable, oxygen should be stable. Otherwise you start suffering, you get headache, you get that?
Yes.
Okay? So we deprive, and that's what we call it autoregulation. Now how we reflect it in histogram. So let's do now histogram here and histogram here. And let's see the difference. This is stable, right? So if I give you a period of stability of oxygen, and let's say stable is 95% saturation, correct? It's usually lower than that. But let's say stability that your oxygen carrying to the tissue is 95, correct? And in the brain, and in the vein, in the body, this is the arterial. And let's check the vein. So in the kidney, it should be higher. So let's say it's 80. This is RO2, somatic, or kidney. In the brain, should be lower. So in the brain, should be 60. Okay? So that's first feature. This brain nears is almost always is 20 to 25% below that. So if we go to the kidney and have a histogram, these are periods. This is less than 40. This one is 40 to 60. This one is 60 to 80. And this one is more than 80. Which one is more stable? Should be. Which organ is more stable?
The brain is
The brain. So it has to be here, in a stable area. Correct?
Yes.
And these should be less, peripheries of the brain. So what we get? Bell distribution. So brain is always what? Centralized. Now let's do the same. I can do this. Let's do the same now for the kidney. Same period. We said kidney is variable. So it goes to the higher and the lower depending on the supply of the brain. Because it's doing autoregulation. Then it will be everywhere. Oops. So it will be here, it will be here, it will be here, depending on that. So it's lateralized, not centralized. There is no bell distribution. So now it's easy. I will tell you, and I will tell you, the brain, the kidneys start to be centralized or skewed, going to the left or going to the right. You know that you're losing your autoregulation. So if we put the needles on a sick baby, on the kidneys, and on the brain, and we ask the system to give us histogram every 6 hours, we have to see this always. If we start seeing it, not seeing it, then we have a problem. We can see the shock 6 to 8 hours before it happened. Why? Because we are losing the autoregulation. Now let's assume the brain becomes lateralized. What happened? The brain is not happy. Something wrong with the brain. Either no pain control, there is pain, or there is a sedation problem, or the brain is not infused, or sugar is getting less, or we are giving less CO2 and affecting the perfusion. So it becomes lateral, instead of centralized, so it becomes lateralized. So if you put a table, if I put a table, and I hope now you start to understand, so if I put a table, and I hope now you start to understand, lateralized, centralized, high, low, or skewed right and skewed left. And we write the brain here. And we write the kidney here, or as an example of that. Okay? So if it's here, it's right, going to the right. Is it normal or abnormal?
No.
Abnormal. Okay? If it's here, kidney, and going to the right side, is it normal? It's abnormal. Okay? If it's here, centralized, is it normal or abnormal? It's normal. If it's here, sorry, this is, no, sorry, I confused you. Sorry, I did mistake. So if it's a brain, and it's lateralized,
No.
it's abnormal. Okay? If it's centralized, it's normal. It's just a picture. The nerves will see it. You don't need to do it. They will tell you. It's normal. The nerves will go, oh, doctor, abnormal, lateralized. Come and see something. Something is going on. If it's high,
No. That's
abnormal, you're hyperoxygenating. If it's low, you're underoxygenating. Now the kidney, is it like lateralized? Normal, because the autoregulation is working. If it's centralized, abnormal, because you're losing the. If it's high, abnormal, because you're hyperoxygenating. If it's low, and then now the difference between, and that's what I do with meals when I connect it to the baby. It helped me a lot. Okay, so which one should be higher? Remember, we're measuring the vein. Which one should be higher?
the brain.
The kidney.
Sorry.
Because kidney is not consuming.
Yes.
Okay, so the difference, always kidney more than brain. Normal or abnormal? Normal. If the brain more than the kidney? Abnormal.
Well,
صح؟
just to make sure that I understand difference between what يعني
Saturation, near oxygen saturation of the vein going out of the kidney and the vein going out of the brain.
Yes,
Which
yes.
one is carrying more oxygen?
Yes. So kidney
one-
more than the brain.
From the organ consuming less.
Yes.
Which one is consuming more?
Yeah, the
The brain.
Yeah.
So the vein of the brain leaving out have less oxygen.
Yes.
So the brain has to be always, and that's the difference.
Yes.
Baseline. And that's music. That's all. You put pictures, 6 pictures, and the nurse will pick and will call you. And we can do the same for heart rate. Now you understand the news?
Yes.
Let's do one for heart rate and I will be done. So today we always only talk on one feature of smart monitoring, but we have more smart monitoring. I don't want to complicate it. Okay, so let's say heart rate. And what's the normal heart rate for a baby just born? 120 to 160. The youngest you are, the less gestation you are, the more the heart rate.
Yes.
And that's what we can get based on the heart. So if we write an histogram for heart rate, and we write periods. Okay? So this period, let's say, because we said 120 to 160. So let's say this is less than 100. And this one, 100 to 120. And this one, 120 to 160. And this one, 160 to 180. And this one is more than 80. What is the normal or a stable baby doing nothing? We said 120 to 160. So most of the time the baby should be here.
Yes.
Correct? And less should be here. And more time should be here. And more time should be here. And less should be here. So you have balanced distribution.
Yes.
Okay? It's called centralization. Okay? Let's assume it's not centralized. The baby is spending more time in the periphery. So let's say it's a scoot. In here, you have like this. You have less toward the bradycardia.
Means
Okay.
he was in stress. Yes.
So what does that mean?
He was in
You are
stress.
either sedated, or sleep, or comatose, or you have a rhythm problem. Let's assume you are on this side. We're going toward the tachycardia. You just picture, you show to the nurses, and the nurses will tell you everything. You just train them, and then tell the resident what exactly they do when they find it. You can do it like this. So it's good to this one, toward the tachycardia.
Stress.
Combine it with near infrared, combine it with the blood pressure. You will find the situation. I will show you how to do the blood pressure. So now this is good to the right, toward tachycardia. So you have no tachycardia. You know, in last 20, even if it's okay, in last 24 hours you have a problem. Now you can have it scattered to this side and to this side. So your heart rate is everywhere. Sometimes in the brady, sometimes in the tachy. And most of the time, this is baby was in pain. Most of the time, or sleep deprived. Now you can combine it, smart monitoring with the blood pressure. تعبتوا؟ اسكت؟
لا لا
والله ضغطوا؟
وانت اللي لا
والله ممتاز.
لسه
Okay. So now, how many methods of measurement of blood pressure?
في invasive ولا invasive.
Non-invasive and invasive. That is the delivery method. But what is the method of actual measurement? How we measure the blood pressure? You guys know? We use mercury, Korsakoff sounds, and we use PTT, pulse transit time. PTT. That's the pressure measured in the machine. Or we use the Korsakoff sound. With the changes of the Korsakoff sound, we assume that this is systole and that's diastole. Or we measure the pulse transit time. Because each wave moving with the heart contracting, it will be a stroke. And this stroke will start moving, and once it moves, the blood vessel will dilate, and then recoil, and then they recoil in a propagation, so they contract from here, and they relax from here, and the pulsation keep moving. That is called pulse transit time. So if you measure pulse transit time here in point A, and pulse transit time in point B, okay? The max of the difference is the systole, the mean of the difference is the diastole. That's all. So it's used the pulse transit time. We can use it by image instead of probe. So they call it IPTT, or imagery pulse. We don't want to go to this part. We'll talk about blood pressure only. So in the blood pressure, we have systole, correct? We have systole, and we have diastole. Okay, and the difference between them is pulse pressure. Correct?
Yes.
Pulse pressure. What's the normal pulse pressure in newborns? Any idea? No? Okay, what's the range? Any 24. 20 to 40. Yeah. You're very close. It's usually it should be less than 25. If it's more than 25, you know that. But I don't use this. I use smart monitoring. Okay? Now we have two numbers. You have systole and you have diastole. And you have pulse pressure. What's the benefit of the mean? 0. No benefit. Okay, it's just number to make our life easy. It has 0 benefit. It has 0 contribution in the diagnosis. We don't use it. Okay? So now let's look. We have two numbers. So first physio feature is what? What's the physio
Changes the
feature?
variability.
Event to event variability.
Variability.
So if we take the blood pressure every 15 minutes and then compress it. So you will see it like this. And if you keep doing it, you will get a picture. Okay? First, you'll see event to event variability. If you compress it more, you will see a picture. and you will see the rhythm of the blood pressure. And you will see the response to noxious stimuli. And you will see the seasonal variation. And you will see the gender variation. So first thing you see, event-to-event variability. One, if there is no event-to-event variability, you're giving up. Your autoregulation is gone. You have a problem. So once the nurses see it like this, they will call you. They have to see it in this way, always. Going up and up. Once they see it, they always compress it. So each shift, they come, they compress, they look, they see the picture, they have laminated, they tell me, doctor, no event-to-event variability. We have a problem. We're getting shock. Now, remember, they're measuring everything, not only the blood pressure. So first thing is what? Event-to-event variability.
Yeah.
Second is rhythm.
Yes.
Third, wakefulness, sleep cycle, they will observe. Okay, so that's one. Other one they will start to observe is the difference between systole and the diastole, correct? Which is the pulse pressure, correct? The difference between systole and systole is the pulse pressure. And this relation can be like this. It can be like that. It can be fixed, both going up. صح? Blood pressure, systole and diastole going up both, and there is no difference between systole and diastole. The relation are the same pulse pressure. صح? So this going up, and this is even. صح? So that's one sign, everything is going up. Or the other sign is like this. Both going down. So this is going down, this is going down, and this is even. Or it can be like this. Diastole is fixed and systole is going up. So this is same, even. This is increasing, and this is increasing. Or it can be like this. As another picture. So this is decreasing, this is increasing, and this is even. Correct?
Or that can be divergent.
What else? They can meet instead of going like this. Or they can separate. Correct? So each one has an explanation and has inotrope to be started with. You can select inotrope based on these pictures. So what they do, they check the blood pressure and they look. Doctor, both of them going down, especially in newborn babies, because one of the problems of newborn babies is the blood pressure. They cannot maintain part of prematurity. Okay, and you get the picture. And then we can discuss in hemodynamics which inotrope we select based on this. We don't need echo, we don't need anything, we just need the blood pressure. And I'm going to stop here.
Do we need to look for it, or
Huh?
do we need to look for which is which? I mean,
Oh, you want right now? We'll do it. We can do it if you want.
and by the way,
Yeah, it's better to finish this latest part.
Oh, okay. So which inotrope you will select here? What you will do here? The diastole is the same, and the systole is going up. What's going on? From where the systole is coming? And you have wide pulse pressure. So the diastole is the fixed, not changing. The systole is going up, and you have wide pulse pressure. What's the problem right now?
prefer
The
resistance.
heart. The heart is pumping.
Yeah,
Okay?
prefer resistance.
Or peripheral vascular. Well, no, but if it's a peripheral vascular resistance, the diastole will go up. But diastole is staying the same. You have only systolic problem. The heart is pumping. So either you are in pain,
Yeah.
or you're giving inotropes. That's the only explanation. You need to control the pain, to sedate, or to wean the inotrope.
Yes.
So you can do it. So let's say this one is going up. Like this is formed. What's going on here? This stone is going up, systole is going up, and there is no difference between diastole and systole. What's going on?
Could be an inotropic effect also. This one.
Inotropes, everything is going on. So inotrope, chronotropes, affecting both. So if you are, which ones can do like this? Which medication can do this?
Dopamine.
No.
Epinephrine.
Epinephrine.
Yes.
This is epinephrine effect.
Yes, yes.
Okay? Or a combination of dopamine and maybe norepinephrine.
Mm. Mm.
Okay? Now let's assume it's this. Systole is fixed, diastole is going down, and the pulse pressure is widening. What's the problem now?
Shock.
It's a peripheral vascular resistance problem.
Mm.
Okay? So let's assume we want to select inotrol. Which inotrol will select?
Norepinephrine.
Norepinephrine or dopamine?
Norepinephrine or dopamine? Why? Why norepinephrine?
No, because it affects the.
Depends on the sodium.
Oh.
You have to check the sodium. Is the sodium high or low? You select and I will tell you which inotrol. If the sodium is high, use vasopressin because it drops the sodium.
Mm.
If the sodium is low, use norepinephrine because it maintains the sodium, while the vasopressin causes dilution and it drops the sodium.
Mm.
Okay, so let's assume it's this. What's going on here? Both are dropping, pulse pressure are the same. Diastole is dropping, systole is dropping. And remember, we said diastole is coming from where? It's a recoil for systole.
Mm-hmm.
So the only reason that both drop is the systole is dropping. And systole is wrong going. So we have the heart is going. So we can give what? Dopamine. Or adrenaline. Okay? What else? Now they are separate. What happened here? This going up and this going down. Okay? And the pulse pressure is widening. So we have heart is working very efficient and trying to compensate. And the peripheral vascular resistance add
PD.
below. Okay? So we need to quiet the heart and we need to increase the peripheral vascular resistance.
Could it be due to BDA in this case? No.
No, what are the causes if you want to list the causes of heart rate is doing good? Okay? Medication. Fentanyl. Fentanyl will give you this. Most of the time when you give fentanyl, we give you this patient. Just keep giving fentanyl 2 mic per kg per hour and check the blood pressure and look at the patient. If this, wean them. And that's what dexmedetomidine will help. So this is typical sedation problem. But when you say sedation, sedation analogy is a narcotic. Which one? This one. What's going on? Heart rate is dropping, the cardiac is dropping, and the peripheral is going up. They are meeting together. They become narrow pulse pressure. What happened here? The heart is working against closed door. There is volume overload. So you need diuretics. So what you do lung ultrasound, you see more B lines than A lines and give lasers. So we'll take it if you guys want the hemodynamics, we'll reach to the hemodynamics and then we can
Pneumothorax can be.
pneumothorax no. Yeah, ممكن, but usually this is a fluid problem. This fluid. You give order, nurse is not checking, you overload with the baby and you get this patient. So when my nurses see this, they will Doctor, recalculate the fluid. Right away they will tell you, Doctor, there is a fluid problem here. Every 6 hours they check, they say, oh doctor, there's a fluid problem. Doctor, we have sedation problem. Just from the pressure. They will tell me. And then most of the nurses, they can check. You can B line and A lines, very easy. Oh, doctor, there is more B lines now. Then I cannot see the A lines. They put the ultrasound. And then they say, we need lasers. They will tell me, doctor, what's the dose you want to give? They know that. So sedation, lasers, which one we're talking about? Now, of course, there's shock and sepsis because there will be the near-infrared spectroscopy, there will be the heart rate, there will be temperature. Now, there's a group of, and then most of the time, we can diagnose shock 6 to 8 hours before it happens. Most of the time, if you don't have any reason. Sugar is okay, CO2 is okay, sodium is okay, sedation is okay, pain control, baby is happy, a quiet environment, you're sleeping overnight, don't have any reason, blood culture, start antibiotics. And most of the time we can control. 36 hours, there is nothing, blood culture is not growing, stop antibiotics. I thought this way is better than having a presentation.
No,
In
much
drawing
better.
it will be like more interactive.
Yes.
Questions?
Thank you.
Thank you.